treatment and how we're going to approach this. At the same time, it will give us better understanding in how we evaluate the evidence that is available to us and how we can make decisions that may impact the outcome of our patients. And I thought it is very important to start with this slide. We hear a lot about, well, this study is done in mild to moderate disease, in severe disease, or in critical disease. And there is no clear definition of what is mild, what is moderate. And in fact, most of this information came from the early Chinese studies. And of course, nobody would argue about what is asymptomatic, where we have positive PCR, but no symptoms. The mild disease is where we have clinical symptoms that are mild with no pneumonia. There's no manifestation on the chest imaging of any disease in the lungs. When we start talking about moderate disease, this is where patients have symptoms such as fever and lower respiratory symptoms, and we see pneumonia manifestations on imaging, whether it is chest X-ray or CT scan. Now, we get to the severe disease when we have hypoxemia. This can manifest with measurement of O2 saturation, and the definition is less than 93% at a resting state. The patient may have an increased work of breathing with respiratory rate more than 30. That would be looked at as severe disease, even if there is no hypoxemia. Of course, you can define hypoxemia as PF ratio. With a PO2, if you have ABGs, PO2 over FiO2 of less than 300. In addition, progression of radiological manifestations with an increase in the infiltrates, more than 50% on lung imaging within 24 to 48 hours. In the early studies in China, they were doing a lot of CT scans, so they were able to define progression. We don't do many CT scans here, so it is very difficult actually to define progression of radiological manifestations on the chest X-ray. And of course, if the patient is intubated or started on ECMO, that would be very critical, and patients may progress into multi-organ system failure, defined as we have at least 2 organs that are failed for more than 48 hours. Putting this understanding in our mind, you all know that the disease goes into 2 different phases. And to put them here, actually, you see that it is a spectrum. And the more red, that means we're dealing with inflammation thrombosis. More green, that means we're dealing with viral replication. And the disease starts as a viral phase with viral replication, where we have the positive PCR and we have the systemic manifestation of the disease, fever, fatigue, and other symptoms. This would be the condition in asymptomatic, mild, and moderate. When we start seeing the severe disease, at that time we start seeing some inflammatory reactors. We start seeing also some thrombosis. And when we go into more critical, I think the predominant phase would be inflammation and thrombosis. So I think it's very important to look at it this way, where we know where's our patient at in terms of these 2 phases, but there's no line here where it tells me this patient is transformed from viral replication to inflammation and thrombosis. And that's what's make it difficult actually in terms of defining the stage or the phase of my patient, where I can decide whether I need to do antivirals for the patient or anti-inflammatory anticoagulation. And we learned that patients may actually go through different courses. Most of those patients have asymptomatic or mild disease, and they recover without any further sequelae or other manifestations, and the disease is usually mild, and patients may not actually feel it at all. And this is the difficulty, because it's happening when we have a viral replication, and those patients would be infectious to the others. Other patients may actually get the initial systemic symptoms. They may get better. We know that the symptoms may actually improve and then get worse, but they do not progress into a severe disease. They get manifestation of moderate disease. They may have infiltrates on the chest X-ray, but everything gets better and patients recover. And we know that we have patients who progress and go into severe disease, and we may see a biphasic course where the patient gets better, and then when we start the inflammatory phase, at that time symptoms get worse, and patients will go into much more severe course of the disease, and those patients who are admitted to the hospital and the intensive care unit. Now, it is difficult to define what are we going to use to say that this patient transformed from the viral phase into the inflammatory phase. But we have some inflammatory mediators that has actually been studied well enough in the literature, and we know now that we can easily measure the CRP for those patients, ferritin, LDH, and D dimers. Of course, you can measure the interleukin-1, interleukin-6, and tumor necrosis factor, but we don't do that routinely. So that 4 major ones that we can measure would be CRP, ferritin, LDH, and D dimer. And in order to manage those patients, everybody would get supportive care. Supportive care meaning treatment of symptoms or monitoring devices at home, the symptomatic medications. However, we need to define which patients would need to have antivirals. At this point, we're using antivirals for those patients who have severe disease. We're not treating the mild and moderate with antivirals. However, you probably know that yesterday, the study for the remdesivir in mild disease was published in New England Journal of Medicine, and showed that there is benefit of 5-day course even in moderate disease of the infection. So the first question that we're going to be trying to answer is, what are the antivirals available to us? And next, do we have any immunomodulators? Because we're worried about the inflammatory reaction of the body, the cytokine storm syndrome. Well, can we modify this? Can we do some immunomodulation to lessen this reaction in the body and improves the outcome of disease? However, we don't have any good studies actually that I'm going to be able to publish to present to you today. They haven't been published yet, and we'll see what the near future is going to bring us with this domain. Now, the third category of medications would be the anticoagulation agents, and we will be talking briefly about whether we have good evidence or not. And then the last one would be the anti-inflammatory agents. And as you see that I put them together similar to each other actually. I'm not sure if we should start the anticoagulation just before we start anti-inflammatory agents, or we need to start them at the same time. But the immunomodulators, I thought that it should be started at an earlier stage than the anti-inflammatory agents, if we get any studies to support the use of immunomodulators. So we need to get more knowledge, more studies in order to define exactly who are the patients who are going to benefit from the anti-inflammatory agents versus anticoagulation. So what I did here, actually, I put these four modalities of treatment in this graph here. And I put the antiviral medications on this side, and then the anti-inflammatory agents. We have the immunomodulation, or I added to that what we call organ protection. Do we have any medication that can protect organs from the inflammatory reaction of the body? And then the anticoagulation. And what I want to do right now, I want to just click next and see what agents do we have in each category. And you can see that the different circles are going to pop up in front of you. And believe me, I got tired of adding more circles. And you probably know this from the messages that we get. We get actually more on our social media, information on our social media about medications here and there that are actually people are looking in. Most of those medications are already available to us, but we are testing them in different phases. So let's take one by one, actually, and let's see. You probably see that there are different colors. And when you see the dark green, that means we have studies showing established clinical and mortality benefit. And you probably see that the only circle that is dark green is steroids. When you see the light green, that means that it is established clinical benefit with a trend towards better or improved mortality. And the only medication that falls under this category so far is remdesivir. When you see that the circle is orange, that means we have some data. This data could be conflicting. They are published, some studies, small studies published showing benefits, but we are waiting for larger studies to prove to us that this is improving outcome and clinical course of the disease. And this is applicable to the convalescent plasma, to the tocilizumab, and you've probably seen the different studies that are published, and the company has released the results of their study for tocilizumab that is actually not benefiting patients, but we have other studies published showing that the medication may benefit in certain type of patients. So we need more data in order to make a decision. Similarly, convalescent plasma is very conflicting, but also we have some studies support its use. And the other things that is actually put here in orange are those medications or modalities that are very plausible. They make a lot of sense based on our observations, based on the autopsies, the results of these autopsies, and that is applicable to the anticoagulation. So we have some studies, mainly from China and Netherlands, about use of anticoagulation for those patients, but we do not have a full confidence that everybody should be anticoagulated. But we feel that everybody who's severe enough in his disease should be, in his or her disease, should be given intermediate or high dose prophylaxis, but not full anticoagulation. At the same time, we do have some epidemiological studies showing that vitamin D3, those patients who had deficiency in the vitamin D may actually benefit with adding this medication in terms of decreasing the severe. Let me put it this way. We've seen epidemiological studies that those patients who have vitamin D deficiency have much more severe disease compared to others who do not have the deficiency in their body. So we don't know whether adding this medication is going to benefit those patients. But we know that there's not much harm if we add supplementation with vitamin D3 for short time, for short period for those patients. Same thing applies to vitamin C and possibly zinc. So that's why I put this in orange color here. And then we come to the red color, and thanks to the recovery trials that actually told us that hydroxychloroquine, even though still been challenged, especially in the political media, about whether it's going to benefit or not, but we stopped using hydroxychloroquine for those patients as antiviral medication. Similarly, the recovery trials told us also lopinavir ritonavir is not helpful in those patients. Now you can see that a lot of circles are still gray. That means that there are no published data yet, but we have some plausible explanation, not very well studied yet. But in terms of antiviral, we're looking at favipiravir, berofavir, the cloviden, the ivermectin, monoclonal antibodies, nitazoxanide, and hyperimmune globulins. And of course, there are much more than this actually, but I put only examples of other available medications for us. As anti-inflammatory agents, we're waiting for the azithromycin, the anakinra, quercetin, baricitinib, radiotherapy, low-dose radiotherapy, colchicine, sirolimus. Of course, not only the tocilizumab, we have other interleukin-6 antagonist, receptor antagonist, where we are waiting for the results of the studies too. The vasoactive intestinal peptide, mesenchymal stem cells, I put this on border between inflammatory and modulation because they do have both properties in those patients. And then you can see here the immunomodulation, mainly what we're looking at actually hopefully we get the results very soon, the interferon beta 1 alpha, fenofibrate, metformin, hyperbaric oxygen, the angiotensin 1 and 7, and then of course don't forget the statins that may have a role as they have properties for immunomodulation, anticoagulation, a little bit of anticoagulation and anti-inflammatory properties. So with this, I want to say that at this point, for sure, we do not use hydroxychloroquine, lopinavir, ritonavir. For sure, we would be using remdesivir, mainly in early phases of the disease. And for sure, we would be using the steroids for those patients with defined criteria when we have enough confidence that our patient is actually going into the inflammatory phase, and what we're using right now is the level of oxygen. But I do not have any problem at this point if in the countries where patients are not enrolled in studies to use convalescent plasma or tocilizumab. In countries where we do have those trials, I would prefer to use those agents within the trials so we can actually get more information sooner and quicker, like what happened with the steroids, and benefit our other patients. Similarly, I would be using the high-dose prophylaxis for those patients in the intensive care unit mainly. So with this, I would like to say that we need to emphasize and we need to actually promote enrollment of patients in well-designed trials. And I want to thank our colleagues at Oxford University and in England. I think 15% of all patients who had COVID in England were enrolled in studies. This is remarkable. The enrollment was very quick. The study protocol was designed very nicely. Yes, it is not complete. However, it gave us valuable information that guided us very shortly. Within 100 days after the pandemic started, we were able to say that we have two medications, and they put them in red here again, the same colors that we used, the color code that we used in the previous slide. The lopinavir, ritonavir, and hydroxychloroquine are not helpful, and we do not recommend their use. However, the dexamethasone is helpful in those patients with severe disease where they have inflammation with more than 7 days and they have hypoxemia. They benefited from dexamethasone. At the same time, we are waiting for the results of the azithromycin, tocilizumab, and convalescent plasma. On the other side, here on the left, the adaptive COVID treatment trials. Both those trials are adaptive, meaning that one arm for usual care and the other arm is adapting the new interventions and medications that are proved to benefit our patients. So once we know that an agent is benefiting our patient, that agent will be moved to the usual care. Like now, every patient with severe disease and hypoxemia would get dexamethasone compared to the other intervention that we're still in study. Remdesivir, as I said, light green, because we don't have enough confidence that it improves outcome, it improves mortality. It certainly hasten or speed up the recovery of the patient in terms of the clinical course. There's a trend towards lower mortality. However, there is no confirmed data yet that it improves outcome in terms of mortality. That's why it is in light green. We are waiting for the other two agents that are studied under the adaptive COVID treatment trials, and this is in the United States, the baricitinib, which is Janus modifier, and then the interferon beta-1 alpha. At the same time, if you go to clinicaltrials.gov, you will see today that we have more than 213 randomized control trials, but those actually not within the design of a adaptive design of the studies. They are actually from individual institutions. Some of them are repeatable institutions, others are scattered around the world. We have to be careful with the results of any randomized control trial that we have available in our hand. And I want to go quickly through the knowledge that is available to us on steroids, because I think we need to emphasize that different than other diseases in the past, like the MERS and the SARS, where the viral replication takes longer actually, and in fact peaks on the second week. In SARS and MERS, the steroids did not actually show that will benefit our patients, and in fact we were worried that it may harm our patients. And the same thing with COVID. Initially, we were very careful. We were thinking that, well, those patients may not actually benefit from steroids, especially if it started early on during the course of the disease. Turned out that the viral replication in COVID is relatively early in the course of the disease, within the first week. So probably after 1 week, when we have inflammatory markers indicated by hypoxemia or any other markers, at that time those patients may benefit from the steroids. And we learned this early on actually. So you can see different than the other modalities like hydroxychloroquine and others, we've seen conflicting results from so many studies. However, I'm not going to go through the details of this, just look for the thumb up or thumb down. The first study is actually 78 patients. It was positive. So this is probably around March, and this is a Chinese study. It is retrospective study, used steroids and looked for clearance of pharyngeal PCR. So it was a positive study. The second study is retrospective cohort of a small number of patients, also from China, but it was positive. The third one was a randomized control trial, but with other agents. They looked at the subgroup of those patients who received steroids, and it was also positive. 50 patients versus 34 patients with ARDS. And this one from Henry Ford System in the United States. This is actually published after the recovery trial, and they looked at pre and post 81 patients before they implemented a corticosteroid protocol versus 132 patients, and it was also positive with decreased mortality from 54% down to 35%. But the most remarkable data that came out actually came from Oxford University, and the study is part of the recovery trials. Recovery stands for Randomized Evaluation of COVID-19 Therapy, and it is a well-designed study, looked at 28-day mortality for those patients who had dexamethasone at a low dose versus usual care for all the severe cases that were admitted to the hospital. So they looked at everybody who's admitted to the hospital, and if they received a dexamethasone 6 milligrams every day for 10 days or till the discharge from the hospital, their mortality rate was 22.9%. Versus 25.7% if they received usual care. And this was actually very statistically significant and given us a rate ratio of 0.83, meaning that patients can benefit from dexamethasone in terms of mortality. And now when we looked deeper in the data, the mechanically ventilated patients are the patients who benefited the most. Mortality rate was 29% in dexamethasone group compared to 41% in the usual care. This is giving us a rate ratio or risk ratio of 0.665. This is remarkable, and with a very good 95% confidence interval. If we repeated this experiment 100 times, we are confident in 95% that our results will fall between 0.51 to 0.81. This is very remarkable, p-value of less than 0.001. And even those patients who received oxygen without invasive mechanical ventilation, they also benefited from dexamethasone with 23% mortality rate compared to 26%, risk ratio of 0.82 and a p-value of 0.002. And this is just to put it in the forest plot graph for you, and you can see clearly the invasive mechanical ventilation and the oxygen only patients benefit from the treatment. Now the question is, what about the other patients? And you can see that the interval here is actually good towards usual care. Those patients who did not require oxygen in this study did not benefit from the dexamethasone. And in fact, we are very worried about maybe they did worse. So there's no good data to tell me that those patients would not, those patients would do worse. However, we would be very careful. We would not be using those the dexamethasone in those patients who do not manifest with hypoxemia yet. So there is no benefit in patients with no oxygen or ventilatory support, and we do not recommend it. Now, if you take a look on the study, also the study showed that the patients who are less than 70 years old benefited more than those patients who are more than 70 years old. And you can see how it's crossing the midline, and the most benefit are in the younger, the most benefit is in the younger population of the study. And similarly, men benefited more than women in the study, and more remarkably, those patients, and this is actually goes along with what how we started this talk, is we need to differentiate between the viral phase and the inflammatory phase. And this is actually proven to you in front of your eyes here, that those patients who had the disease for less than 7 days did not really benefit from dexamethasone. Those patients, and despite the fact that those patients were admitted to the hospital. So not necessarily if the patient is admitted to the hospital with severe disease that they're going to be benefiting from dexamethasone. I think what we're looking for is markers of inflammation, and this is, in this study, is defined as use of oxygen or mechanical ventilation. So there are still questions in this study that needs to be discussed, and we don't know whether we have more data coming. I know that they're doing the dexamethasone now in pediatrics, and I'm not sure if we're going to get more information about it. So the first thing is that the study does not provide us with data on viral load. They did not measure data in their study about this, and we have a question mark whether is powerful enough to say that, well, those patients who are older than 70 years or older, or the men who do not benefit from this, I mean, the women do not benefit from this as much as the men, and those patients who are 70 years or older do not benefit as much as the younger ones. So we have a question about that. Now we're not making that differentiation when we apply it in practice. We're applying it to everyone unless there's contraindication to the use of the medication, which are very limited. Now, the question also that came up in the communities among physicians and practitioners, are the higher doses harmful? Should we use higher dosages? Or are they more beneficial? And you probably know that there's a study about ARDS that came out around February in the Lancet, looking at a dose of dexamethasone of 20 milligrams for ARDS patients. And some physicians are actually using the 20 milligrams. However, I would say if you look at the study, it has a lot of limitations compared to the recovery trial, and I would not be recommending a higher dose of dexamethasone. Similarly, people are actually saying that, well, what about other steroids? Does it have to be dexamethasone? Well, the medication that's studied in this trial is dexamethasone, but of course, this can be extended to other agents, and especially the other studies that I mentioned are actually studies that used methylprednisolone or any other agents. Can inflammatory markers determine timing of steroids? Like, does it have to be related to the hypoxemia? In my mind, no. It is very plausible to say that once inflammatory markers peak in the body, at that time maybe we should consider steroids for those patients. However, I don't have any study to support this or guide us towards using any specific inflammatory markers. We need more data to before we can actually implement this. And finally, combination with other anti-inflammatory markers such as tocilizumab, and you're probably aware of the study that was published with using methylprednisolone in addition to tocilizumab, and that was published in Rheumatology, Lancet Rheumatology. So going back to the first slide I started with, so we have agents that are studies for antivirals at this point, negative for hydroxychloroquine. Remdesivir is positive, no mortality outcome, negative for lopinavir, ritonavir, and we're awaiting data for convalescent plasma. Immunomodulators, we are waiting for the interferon study. For anticoagulants, we prefer to use enoxaparin because of its anti-inflammatory property, and shy away from heparin as much as possible. We use risk-adjusted strategy to initiate anticoagulation in prophylactic dose at 0.5 milligram per kg every 12 hours of enoxaparin once the D-dimer hits 6 times above upper normal limit. And we preserve the use of direct oral anticoagulants for outpatients only. Anti-inflammatory agents, the dexamethasone is given to those patients who are hypoxemic. We're waiting to see more data about tocilizumab. The anakinra, good study published, but we don't have a good randomized large-scale study to support it. And the ACTT trials for the baricitinib, hopefully very soon. With this, I would like to stop here and see if you have any questions.